welcome everybody. Good evening here in the UK. Welcome to the Journal of Hand Surgery European Volume Journal Club. We've got two really great papers to talk about tonight, two sciencey, methodological and interesting papers. And we're really lucky to have the authors, the guest editor, and some experts. And what we're going to do tonight is we're going to look at these papers in detail, talk about some of the points of the studies themselves, and also take them into real-world clinical practice. How do these papers actually affect what you do? So thanks for joining. I'm Jeremy Rodriguez. I'm a consultant hand surgeon here in the UK. We have our team from the digital committee who put this together, and we're joined by two of the hand fellows from the UK and Europe, Helen and Jantien, who are kindly going to present the papers for us. We've got the authors. So Justin, thank you very much for joining for your paper on quality of life after carpal tunnel release. And we also have Dominic Furness and Jenny Lane joining to talk about the association between bariatric surgery and Dupuytren's disease. And we'll look at how that impacts clinical practice as well. And we're lucky to have special guest experts tonight. So thank you very much. Paul Verker joining from Groningen in the Netherlands, and Duke Brekstra as well, also from Groningen in the Netherlands. I'm excusing my terrible pronunciation. And David Warwick from Southampton as well. And we're going to really enjoy discussing and picking over these papers in a bit of detail. And the editor tonight is Wee Lam. Congratulations, editor-in-chief now of the Journal of Hand Surgery European Volume. He's going to tell us a little bit about his insights into these papers as he was handling them during their submission process. So without further ado, we'll go on to the first paper, which is looking at change in quality of life scores before and after carpal tunnel release. So thanks very much, Helen.
Thanks very much for the introduction. I'm a micro fellow working at the Royal London. The paper I'm presenting this evening is the effect of carpal tunnel release on health-related quality of life of 2,346 patients over a 5-year period, written by Justin Posma and Marius Klemner, working in the Martini Hospital in the Netherlands. This study uses a validated questionnaire to investigate changes in quality of life experienced by carpal tunnel syndrome patients following decompression. They also report on how these changes in quality of life compare to other disease processes. So we don't know a lot about the disease burden of carpal tunnel syndrome. This study uses the European Quality of Life EQ5D questionnaire. This is particularly interesting as this questionnaire allows us not only to compare changes in quality of life following decompression, but also to allow us to compare with different pathologies, for example, diabetes or cancer. It measures 5 domains: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. It can be administered to a group of individuals with a pathology, for example, carpal tunnel syndrome, to determine the quality of life they experience and how this might change. It can also be administered to a healthy population. When the questionnaire is administered to the general population, we ask them to imagine what it might be like to have a disease such as carpal tunnel syndrome and what they think the quality of life might be like. The mean of the questionnaire scores is called an index value. The patients were recruited to this study prospectively between January 2014 and January 2019. They were included if they had clinical symptoms and a positive neurophysiology test, and they were excluded if there was any missing data on the questionnaire form. The authors performed a literature search to define some key values before beginning: the Dutch EQ5D index for carpal tunnel syndrome, the EQ5D index value for carpal tunnel syndrome in other countries, and diseases with a similar score index value to carpal tunnel patients, so patients suffering from other conditions, for example, migraine, who might be experiencing a similar quality of life. The EQ5D was administered pre-operatively and 6 weeks post-operatively, and a second questionnaire on the symptoms of carpal tunnel syndrome was administered at the same time. The cost of care was calculated by selecting 5 patients at random, obtaining the insurance company costs for the outpatient care in neurology, plastic surgery, the neurophysiology test, and the decompression itself. This section of the presentation is about the results, and we'll talk about the demographics of the patient group. There was a 5-year recruitment period from January 2014 to January 2019, identifying 2,504 patients that were eligible, but of these, 158 were excluded due to missing questionnaire data, giving a total of 2,346 patients, with a mean age of 59.9 years and a range of 13 years to 79, with 68% of respondents being female. This table shows the results of the EQ5D questionnaire for every patient included in this study. The questionnaire domains can be seen across the top of the table, with mobility, self-care, usual activities, pain and discomfort, depression, anxiety, with a score pre-operatively and post-operatively. The results are reported by levels, seen on the left-hand side. Level 1 indicates no problems, level 2 indicates some problems, and level 3 indicates extreme problems. And this table demonstrates that the scores improved in all domains. The average EQ5D score pre-operatively was 0.75, with a standard deviation of 0.23 and a range of negative 0.2 to 1. The index value ranges from 0 to 1, where 1 indicates perfect health and 0 indicates death. So a negative score is possible if the symptoms experienced are perceived as being worse than death. The index value post-operatively was 0.87, with an increment increase of 0.12, which was statistically significant. This table shows the results of the Carpal Tunnel Symptoms Questionnaire. At the bottom, we have the 5 domains measured: loss of strength, pain in the daytime, pain in the nighttime, numbness, and paresthesia. The blue bar represents the pre-operative results and the grey bar is the post-operative results, and they had a statistically significant reduction of symptoms in all of the categories demonstrated here. And the most commonly reported post-operative symptom was scar sensitivity, with 78% of respondents reporting this symptom. The average cost to the insurance company for treatment per patient was €1,029.73, and the average patient gained 2.6 quality adjusted life years. Therefore, the cost per quality was calculated as being €396.05. This table shows the index values for other common pathologies, with carpal tunnel syndrome highlighted at the top, with the British results on the left and the United States on the right. It is interesting to note that disease processes such as diabetes and breast cancer have similar index values. And I think this is particularly interesting in the context of COVID-19, where many hand surgery centres have experienced significant delays in routine elective procedures due to perceived diminished importance. But this suggests that the potential gains in quality of life are significant and should not be ignored. So in conclusion, this paper shows that patients who have decompression experience a significant improvement in their self-reported quality of life. And carpal tunnel decompression offers €396.05 per quality gained. It has been quoted that non-operative management costs are €521.42 per quality gained. So this actually represents good value for money. And 78% of patients reported scar sensitivity. The authors attribute this to an early follow-up, and I tend to agree with this. So I think this is a really good study, and it's really well designed. Because of how cases are coded in the Netherlands, this sample represents only patients with carpal tunnel syndrome, which is not the case for many other studies. The data was collected prospectively over 4 years, and the sample size is large. The questionnaire has an 100% response rate, and the EQ5D is a highly validated questionnaire tool. The demographics suggest that the results are highly generalizable. However, no study is perfect, and there are some pitfalls. There's no information included on how the 158 patients excluded differ to those who were included, and we don't know anything about them. The study does have a selection bias in that only those referred for carpal tunnel decompression were included. The 6-week follow-up is short, so we don't know if the benefits are sustained, and we don't know if the patients have a previous decompression or mononeuropathy at another site in the same limb. The cost calculations were only taken from 5 patients rather than the entire sample. So what does this paper actually mean for my patients? So for the majority of patients, there is evidence to support the likelihood that most patients will experience an improved quality of life following decompression. And for those of us who are involved in decision and policy making in healthcare, it's likely that decompression represents very good value for money. So my question to the author relates to future research. Do you think that the improvements in quality of life and quality adjusted life years will be sustained over a lifetime for individuals with carpal tunnel syndrome following their decompression?
Thank you, Helen, for your presentation. Yes, I think it's a very good question, but also a difficult one to answer. Because I think in theory, you could say, yeah, you solve the carpal tunnel disease, so there's no reason why the effect would decrease unless they get a recurrence of the carpal tunnel syndrome. But practically, I think health-related quality of life is dependent on so many factors, and it's still a subjective measure. So at one point in time, a patient could think about the results of their disease differently from a moment in the far future. So I think it's difficult to determine whether the effect will be sustained. And I think it could be an idea to have some reduction in the effect over the course of time, as proposed in previous literature, a standard 3 to 5%, I think. So yeah, I think it's still difficult, especially in elderly patients and with comorbidities. Health-related quality of life is affected by so many other factors as well. So yeah.
So interesting points to think about this. Yeah, and obviously you've got a cross section at 6 weeks. On a complicated area. Paul Verker, you've done a lot of research, done a lot of outcome measurement research. How did you find this paper? What were your thoughts about here?
Thank you, Jeremy. Well, first of all, I would like to congratulate the authors for this very nice paper, and also Helen, thank you very much for presenting it so nicely. Just for the audience, maybe it's good to know that the Martini Hospital is actually situated in my little town. And I was already wondering where all the carpal tunnels went, but now I know where they have been treated. So, and I think that they actually were treated in a proper place, because the improvement that was found in the EQ5D of 0.12 is significant, and it's good to see. The question that I would like to ask Justin is, we as plastic surgeons, at least I'm a plastic surgeon, are not very familiar with the EQ5D. And I was wondering if you could maybe allude a little bit about the clinical relevance of that questionnaire, and whether the findings that you have using the EQ5D would also stand if you had been using a very specific disease questionnaire that is also available for carpal tunnel.
I think the clinical relevance of the EQ5D questionnaire is the ability to compare your results with other diseases. So you can, in the hospital, you can see what kind of the quality of life and the improvement over therapy is. And you can compare it to what you gain in improvement for other diseases with other therapies. And I think with a specific carpal tunnel syndrome questionnaire, I think you could have had the same improvement in quality of life, but then you would miss this comparison with other diseases, which I think is very interesting in our paper.
So that's it's an interesting point here about this, about being able to look sideways and make these kind of comparisons, as Helen kind of alluded to as well. And yeah, Paul, it's a really interesting point about clinical relevance. And I wonder if Duke also has a comment about this. You know, so Duke, is really great to have you here, not only as an expert invited, but also somebody in-house in the journal with your statistics hat on. And I don't know, would you have a comment about that? Because obviously we talked here about this statistical significance that Justin found. What are your thoughts about that?
Well, I'm wondering about my answer now. I think that in general, we shouldn't focus so much on statistical significance, or at least think about it more thoroughly instead of only looking at dichotomously, like it is significant or it's not significant. In my experience, that is often the way that people look at the p-values. Well, actually, it's a continuous value explaining not more of giving you more information than only that. And it's also highly depending on the context of your study. But in this case, because you were interested in, I think, you would expect a beneficial effect of the decompression. I don't see big issues to use statistical significance in this case. And if you would look, if you would be more interested in clinical relevance, then you end up with some non-inferiority studies kind of design, in which you look at the margin of non-inferiority, which is kind of a value of which we agree on as experts that, okay, beyond this value, we talk about, we say it's an important change. But that's that's often not known and also difficult to judge. And I think for this specific paper, it's not really required. It's always, of course, look beyond the p-value, or look beyond the dichotomy behind of the p-value, and also look at the effect sizes and the spread around this, because that tells a lot of information.
Okay, so there's really interesting points, and I suppose maybe those also then translate into how the journal thinks about these and handles these kinds of papers as they come in. And when we talk a bit about that in a minute with we, that's what's so great about actually having we as the editor here. But David Warwick, what are your thoughts here? I don't know how things are in Southampton with carpal tunnel release. I mean, Paul's struggling not just with COVID, but with the martini taking all his work. What's going on there, and what are your thoughts about this?
Well, first of all, congratulations on a really interesting and good paper. And my thoughts were really that, I mean, in Southampton, like anywhere probably in the world, but certainly our NHS, healthcare costs are rising, and there is not enough money to treat everybody. In fact, the UK NHS about 4 years ago had a very clumsy attempt to try and stop carpal tunnels more or less altogether on the basis there was no evidence it worked. And led by David Shearing, one of the past presidents, we rebutted this by using PROMs. So PROMs are obviously very useful, and this paper now gives us EQ5D. And I suppose my question for you, really, Justin, and my thought is along the lines that EQ5D is good. We can compare it with things like breast cancer. You've done that. But all things being equal, if the improvement in quality is the same for carpal tunnel as it is for breast cancer, based on EQ5D, you kind of suspect that the healthcare providers will still favour cancer or something that's very painful, or children's care or something. So how do we get our message across that perhaps the EQ5D is improved hugely, but hand surgery remains as important as anything else when we're competing?
I think I think our paper shows that it has the decompression gives a great improvement in health-related quality of life in these patients. And the costs we found were very low. So I think when you're competing with more expensive treatments, it's easy to, or you can say that with carpal tunnel syndrome, you can help many more patients with improving their quality of life to, well, quite a high level with low cost. So you can help more people. And it's still difficult because, some people need their treatment because it's life-saving. But I think you can still say that you can achieve a very high quality of life improvement with a very simple and easy procedure, which remains low in cost.
Yeah. If I just may add something, particularly as Jeremy asked about what's happening in Southampton, but elsewhere, but I think perhaps we can also improve your figures even better by decreasing the cost even further. And we've been looking at doing carpal tunnels in outpatients rather than theatre, using Wallant rather than more sophisticated facilities. And so I guess we can reduce the cost of some of what we do, carpal tunnel, trigger finger, even further if we're more inventive about how cheaply we can give this treatment, and then actually make our case for funding even stronger.
Yeah, I think that these are really strong arguments. I think we as a community need to be pulling together data like these and presenting them in that kind of way, combine them with efficiency arguments. One thing I was wondering about here, and I don't know what the panel think as well as Justin, is Justin, you've got the people who've had carpal tunnel release, right? So these are the people who've all had surgery, and people come along, presumably quite a few people maybe have carpal tunnel syndrome for a while, come along when it gets really bad, and end up going for surgery and get an improvement. But I wonder, do people think some of the other people who don't have carpal tunnel release may actually up and down a bit? And maybe you go to see the doctor when things are at its worst, and actually you get some improvement just, from the ebbs and flows of things, this kind of idea of regression to the mean. So I don't know if you've got any thoughts about this. I mean, is that gain all from the surgery? And how much of it do you think might just be some ebb and flow? Any thoughts about that? I've got Justin, and then Paul's got his hand up, so I'd really like to hear it from him as well. Justin, you got any thoughts about the rest of the cohort at Martini? Presumably some people don't get an operation.
Yeah, I think the carpal tunnel has these differences in symptom experiencing, as you say. So yes, I think there will be some people who would get better even without the carpal tunnel release surgery. But I think that the improvement in quality of life we measured is mostly from the decompression. Yeah.
I mean, it is certainly a big gain. Paul.
Yeah, the reason I raised my hand is that I'm actually a carpal tunnel patient myself. I like to do a lot of work in my own house, and as many surgeons, when we do some bricklaying or whatever, we usually overuse our hands. So carpal tunnel syndrome, just as trigger fingers and many other things, is often a symptom of overuse. And since I was a bit scared to be operated, I just waited. And it took me about 6 weeks when I had it for the first time before I could operate again, because I could hardly hold the pickup. But afterwards, I was fine. And now only when I go and cycle, I know that I have to put my hands in a certain position on the steering bar, and then I'm fine. So I'm convinced that many of the patients that we treat surgically would also benefit from a non-surgical treatment, and actually by just doing nothing and explain to them what the reason is why they have these symptoms.
It's really interesting. I think maybe the answer, Paul, is when you got bricklaying, you need to get one of your orthopedic colleagues to come along and do that bit for you in future. I think maybe plastic surgeon hands aren't made for bricklaying. I can say that as a plastic surgeon. I don't know. Juko?
Yeah, thanks. I think that of course you don't have the possibility, Justin, but I think that really maybe a good addition to the study would have been to also let the patients who not go for surgery fill out the AQ5D twice with a period of 6 weeks in between, so that you have a comparison. So then you definitely know what the effect that you observe can be accounted to by the surgery itself, I think.
You could also even take it further and also include patients with non-surgical treatments, just corticosteroid injections or splinting or physiotherapy.
Yeah, and David?
Just one more question, if I may, Justin, is that your study finished at the 6 week point and you had a very high prevalence of scar pain. And we all know that scar pain happens after carpal tunnel university. We all know that by 3 months or so, by and large, it's gone. Do you think that diluted your findings? And if you looked at 3 months, say, or even 6 months rather than 6 weeks, you may have shown an even better value for money with carpal tunnel release?
I think so. Yeah, I think if the follow-up would have been longer, I think the health quality of life increase would have been even bigger. especially with the scar sensitivity, also with patients who have nerve damage. Nerve damage takes a long time to heal. So over the course of months, I think it would improve even further. Yeah.
That's interesting because the BSSH president, Jonathan Hobby, is online, and he seems to agree with you. He says that, yeah, there's evidence of ongoing improvement beyond this. So again, it would be interesting, when we think about timing of follow-up, these are kind of interesting points for us to consider as hand surgeons. Have you got the end result, or have you taken a snapshot along the way? So yeah, interesting discussion on that. Okay, I'm just catching up on all the chat here. In the meantime, we've talked about a few points here. Massive cohort study, lots of data here, nicely analyzed. How was handling this?
So congratulations, Justin. Great paper. So we get lots of papers on carpal tunnel syndrome, as you can imagine. So once in a while, a paper comes in that looks really interesting because it seems to be a slightly different angle. Good research question, data, big numbers, very easily impressed by big numbers from big data, but not always suitable for publications. But in this case, I think it is very good reviews. As predicted, the reviewers touched on the 6-week limitation and what would happen after 6 weeks. So I think, Justin, we discussed that, and you elaborated on that more in the limitations. Another strong point from the reviewers was again that it would be good to compare conservative management versus surgery. Again, we dragged that out a little bit more in the limitations to make the paper a bit better. The statistics was quite complicated, so we sort of toned it down a bit to make it more readable. But other than that, I think it was pretty straightforward in the review. So again, I think this is one of the sort of the good examples of a study from big data, good numbers, but interesting research questions, very pertinent topic.
Okay, so there's really interesting perspective from the journal. And Justin's done a really nice study, and he's worked with the data they have available. In other areas, we find this well. We work with the UK Hand Registry, not always having comparators because you've got a data set that's based on people having procedures. But comparative data, talking to the audience here who might be submitting, how much more value do you place on that from your perspective, from the editorial board? Is that something you'd like to see more of?
So big data, I mean, there's lots of advantage to big data, as you know, but as I said, it's very easily impressed by big numbers. But the important thing is to still stick to good research methodologies. There's several limitations in big data studies. There's several limitations in this paper, and sometimes these limitations are not acceptable because it definitely skewed the study. Several studies come with big numbers, big data, and again, it boils down to whether the paper has good research methodologies. I mean, it's no different from other studies. So yes, we welcome these studies, but again, authors should not expect that they will definitely be more favorable because they've got big numbers.
Okay, so it's really useful to, people in the audience, if you've got stuff you're working on, one of the advantages of an evening like this is you get to go inside the mind of the editor-in-chief who has to sift through all of the submissions and get a feel for what they're looking for. Duka, and David, do you have another question? Or Duka?
Yeah, I think that I totally agree with you, that these studies with these large data sets are very interesting. But I think it's also important to know that it doesn't. You cannot answer all research questions using large data sets, because often these large data sets are based on registry data or medical file data. In this case, it wasn't, but this is quite exceptional, I think. And with these large registries, you often have other limitations, like you have the data what it is, and you cannot decide to gather something else. You just have to deal with what's there. So I think that the more original way of clinical trials and clinical studies, observational studies, are also necessary still. So I wouldn't advise everybody to switch now and go for large data, but yeah, you should pick the right design for your specific question and also the right source of information.
Okay, yeah, so that's really useful advice and things I think to think about. And I think that actually segues really nicely for us, because actually we're going to move from this paper, and thank you very much, Justin, for joining us, and Helen for presenting Justin's paper on the carpal tunnel release, and move to another large data set study answering a completely different style of question. So this is a paper we're represented tonight with Dom Furness and Jenny Lane as authors on this paper, which is looking at an association between bariatric surgery in particular and Dupuytren's disease. So, but without further ado, let's actually hear some more about the paper. So Jantien, would you like to tell us about it, please?
So good evening, my name is Jantien Postuma de Boer. I'm an orthopedic surgeon from the Netherlands, and I formerly worked in the University Hospital of Leuven, but only this month I've moved back to the Netherlands to work there. So today I will discuss with you the paper about that was written by Teresa Burkhardt and her colleagues about the association of bariatric surgery and Dupuytren's disease. The background to this study is that the relationship between obesity and metabolic syndrome on the development of Dupuytren disease seem to be contradictory. On the one hand, we know from literature that obesity may lead to a reduced risk of the development of Dupuytren's disease, whereas diabetes mellitus and differences in lipid metabolism show an increased risk in the development of Dupuytren's disease. So therefore, the aim of the authors was to study new onset Dupuytren disease in obese patients who underwent bariatric surgery and had a weight loss after that, compared to the obese patients who did not have surgery. The level of evidence for this study is level 3. It was a cohort study. As a data source, the authors used Swedish health registry data. And it is of note that in Sweden, every person who was born in Sweden or who is permanently residing in Sweden gets a unique code, which is used for registry data. It can be used in different registries, such as life and death, but also in registries for various types of disease. And therefore, individuals can be registered in various registries, and the registries can be compared to each other. As a study population, the authors selected bariatric surgery patients who were operated on between January 2006 and December 2019. All were aged between 19 and 79 years old, and from now on, this will be called the exposed group. As a control population, also the unexposed group, patients were selected who had the ICD code for obesity within the same age group. To ensure that the study population and the control population were as equal as possible, the authors did a propensity score matching using a multivariable logistic regression model. And then finally, risk analysis on Dupuytren's or the development of Dupuytren's disease was done using a Cox proportional hazard regression model. This scheme shows how the patients were selected and entered into the study design. The authors made entry blocks of 3 to 4 years each, and the exposed patients, so the operated patients, were enrolled into an entry block. The follow-up per patient started only 1 year after entry into the entry block, because the metabolic effects of bariatric surgery were expected to become most evident then and no sooner than 1 year. For every exposed patient, 1 or 2 unexposed matched individuals were entered in the same entry block at random time points, but their follow-up also started at exactly 1 year after entry into the entry block. All individuals would stay in this block until the end of the study period, unless they would have a second surgery, for example, in the bariatric surgery patients, to have their procedure undone and return to their original anatomy, or unless obese patients would progress and go for bariatric surgery. In these cases, the patients were censored within their entry block, but theoretically, an obese patient who would have bariatric surgery somewhere in this study could be entered in another entry block later on in the study and be used as another individual. The outcome was that as a first recorded diagnosis for Dupuytren's disease or Dupuytren's surgery as found in the registry. This is another diagram that shows patient selection. And what I wish to point out is that eventually 44,000 exposed patients were identified, out of which around 35,000 were eligible for analysis. These were called exposed episodes. And to these 35,000 episodes, about 55,000 unexposed episodes could be matched. So if you add these two up, eventually around 90,000 episodes were available for analysis. And I think this is an extremely huge number. Then to the results, the authors found that overall, patients undergoing bariatric surgery have an increased risk of developing Dupuytren's disease with a hazard ratio of 1.3, leading to approximately 30% increased risk compared to the non-operated patients. In this data set, women seem to have a higher chance or a higher increased risk on developing Dupuytren's disease following bariatric surgery compared to the men. The age at which patients were enrolled into the study did not significantly affect the increased risk for Dupuytren's disease. But patients who had undergone a gastric bypass surgery had also had an increased risk in developing Dupuytren's disease compared to the patients who had undergone a different procedure. Then finally, the duration of follow-up also influenced the risk of developing Dupuytren's disease, where patients who were followed up for a longer period of time, so the patients who were followed up between 5 to 13 years, showed a very clear increased risk in developing Dupuytren's disease compared to the patients who were followed up for a shorter period of time. I think this graph really nicely illustrates that. The black line are the patients who underwent bariatric surgery, and the dotted line are the unexposed individuals. And after 5 years of follow-up, the lines, they start to diverge, and you can see that the increased risk for Dupuytren's disease becomes more and more evident in the exposed group. Then to the discussion, the authors executed a cohort study in which a very large population-based data set was obtained, and the study subjects were followed up for a very long time, up to 13 years. The authors describe a time-dependent effect on increased risk of Dupuytren disease following bariatric surgery, and this might be due to the fact that metabolic effects of weight loss take a bit of time before they actually start to influence the process of Dupuytren's disease development. A point that the authors picked out to discuss was that BMI baseline levels for the exposed group were readily available because all data was collected, including exact BMI scores, for people around their surgery, but for the obese patients, for the unexposed group, exact BMI levels at baseline were not known. However, because of the propensity score matching, I think it's a valid assumption to say that as the groups were so carefully matched, it's likely that the BMI scores at baseline were equal between the exposed and the unexposed group. Then finally, a point which I would like to ask the authors of this paper is the mechanism through which they think that weight reduction influences the development of Dupuytren's disease. And I know that it's beyond the scope of this paper, but from other literature, it is known that adipose tissue or adipose cells may have a biological influence on the myofibroblasts in the hand. There may be cell signaling or other mechanisms going on. And I would like the authors, whether they know more about that, whether they would like to know more about that, and if they can tell me about that. So by this, I would like to hand over to the panel for further discussion.
That's great. Thank you very, very much, Jantien. And we'll go straight over to the authors. Dom, what do you think? You've got a mechanism for this? What are your thoughts?
Well, it's very interesting, and thank you, Jantina. It's a really lovely presentation, summarized beautifully, and it's a really good question. I think the relationship between fat and Dupuytren's disease is really interesting. So, as you suggested, there's data from Stephen Hovius's lab going back to 2013, where they co-cultured myofibroblasts and adipocytes. And they found that the adipocytes were able to suppress smooth muscle actin expression, suppress the contractile phenotype of those Dupuytren's derived myofibroblasts. They also decreased their proliferation as well. So that's interesting. We know from other papers, so we've published on this, and other groups, Lars Dahlin's group has published, that there is definitely a reverse association between BMI and Dupuytren's disease. So patients with Dupuytren's disease tend to be have a lower BMI than patients without Dupuytren's disease. So we know that from epidemiological studies. And we also published from my group in the Journal of Hand Surgery, the European Journal, in 2021, where we examined this from a genetic point of view. So we did a study called a Mendelian Randomization, where we looked at people who are genetically programmed to be more obese or less obese. And we found an increased rate of Dupuytren's disease in those who are genetically programmed to have a lower BMI, and interestingly, genetically programmed to have a lower waist-hip ratio, which is probably a better measure of the metabolic effects of obesity rather than BMI itself. And then there's a clinical study where, again, Stephen Hovius did needle fasciotomy, effectively, his own kind of version of needle fasciotomy, and then injected fat cells into the palm. And at 1 year, he showed similar outcomes comparing that to limited fasciectomy, although that wasn't sustained at the 5-year follow-up. So there was more recurrence at the 5-year follow-up. So maybe not quite so convincing from that clinical study. So the motivation really behind doing this study was to say, well, in an ideal world, what we would do is we would randomize people to put on weight or not put on weight, and then we'd follow them up for a long period of time and see who gets Dupuytren's. And clearly that's not ethical to do or practical to do. So we took advantage of this pre-existing data set, which has its own limitations. And as Duka said, you have to work within those limitations. And I'm sure we'll come on to discuss some of those limitations soon. But effectively what we were looking at here is, does an intervention that decreases your BMI and predictably decreases your waist-hip ratio, does that cause an increased level of Dupuytren's disease? And that's exactly what we found. So that was the sort of hypothesis and the motivation behind it. As to the mechanism, I think that's still to be worked out.
So lots of things to think, digest. Paul, you're a man who's looked at Dupuytren's disease a lot. I've been reading your studies on Dupuytren's disease for many years. What are your thoughts here?
Well, first of all, I again want to congratulate the authors for this beautiful paper. Really, they have. If you also look at the team of authors from almost every country in Europe, they have collaborated to generate this work. That's really fantastic. I really envy you for doing that. Yeah, I do see a lot of patients with Dupuytren's. In this case, luckily, I don't have it myself, but my wife has it, so I know Dupuytren from quite close. She's not obese, but she is a little bit overweight, so there's something that maybe questions the relationship. What really intrigued me in the paper is that there was such a difference between the two types of bariatric surgery. The sleeve procedure on one hand against the gastric bypass. And if I remember correctly, in the sleeve group, there wasn't a similar association, but in the gastric bypass group there was. And I was just wondering whether the authors have any idea about what caused that difference.
Jenny, do you want to go first on that?
So I think one of the things we always have to talk about in these studies is we never know why someone has had one surgery or the other. And that's the problem with it not being a randomized control trial and using observational data. So we don't really know what was in the surgeon's mind when they decided for one surgery or another. I think other than that, we know that the patients are balanced as much as they can be in every other way. So from that perspective, and certainly someone who doesn't have that more in-depth knowledge of the bariatric side of things, I'm not sure I can pick out why that was in particular. I don't know whether you had a thought on it, Dom.
Yeah, so the other thing, I'm just checking the table for the exact numbers, and I can't quite bring it to hand, but I think power is an issue as well. So I think there were more people having the bypass rather than the sleeve gastrectomy. You can see from table 2 they had a longer observation time, and we know that takes several years to manifest. And the other thing that our collaborators who are experts in bariatric surgery said was that the bypass tends to be more effective as an operation. And so it may well be that the patients who had a sleeve gastrectomy are not as successful in their weight loss.
Okay, so there's some really interesting points there to drill down upon, and again, for the audience reading this, I think some of the nuances and details that are really interesting to look at. Duka, from a stats point of view, there's lots of things to talk about for the audience here, isn't there? There's a really interesting piece of work. What were your thoughts?
Well, my first thoughts was when I reviewed this article was envy, because I thought, oh, I wanted to do this study myself. So that's really want to congratulate and compliment and Dom and the other authors for doing this study, which is I was like, okay, I wish I had made this out and had this idea to do this way, and it intrigued me. And well, basically the major thing that I asked the authors during review was that they should know that they only found an association between bariatric surgery and Dupuytren's diagnosis. So that might also mean that maybe patients going for bariatric surgery have certain characteristics that also make it more likely that they get Dupuytren's diagnosis. I'm thinking about health-seeking behavior or these kind of things. But on the other hand, I also agree with Dominic that given the literature that's already there, I tend to agree with the arguments that they say, like there's also a biological process going on. But if this was the single study on this topic, I think that there might be also maybe some kind of bias there related to this health-seeking behavior, maybe. Well, one of the other things that I really want to say something about is that I think that the audience is maybe not that familiar with propensity score matching. And that was actually what they did in the study. And it's not a magical trick or so, but if randomization is not possible, this is a really nice way to try to balance the groups as much as possible. And what you actually do is that you calculate the probability of being in the exposed group. In RCT, it's 50-50, so it's 50% for the one group and 50 for the other. And for an observational study, this is probably different. And you estimate this score by looking at all the variables that you have observed. And actually, you can match on all these observed variables at once without having the issue of ending up with many variables in your analysis. So it's a really nice way. I think it's more and more used now in hand surgery, and I think that it's definitely a technique that people can think of if they have high risk of unbalanced groups and therefore difficulties with drawing conclusions, and this might be a solution to evaluate.
Cool. So that's something for the audience to have a little bit of think about. Another interesting technique used here. And you're making this point about we have these situations in hand surgery quite a bit, right? Does X cause problem Y with your hand. So I don't know, authors, what do you think? Is this true, or is this just health-seeking behavior?
So absolutely. I mean, you could have Dupatrons and you could never go to your doctor, and you could also have Dupatrons and not actually have a formal diagnosis or have surgery on it. And one of the things that we were concerned about was that people who have bariatric surgery, in comparison to people who are known to be obese, may have different reasons why they undergo surgery that we don't know about and we haven't looked at. And that's why we did the propensity score matching in order to try and make those groups as even as they can be, and compare someone who's had surgery with someone who hasn't had surgery, who is obese, on lots of different factors. And one of those factors, as Duka talks about, is about the amount of times that they go to hospital. And that was a proxy, a way of trying to evaluate how often that person goes to hospital and that health-seeking behavior, because we know that if you've gone to hospital and you've sought treatment for your obesity, you may also be someone who goes and seeks treatment for your Dupatrons. But we have included that in the propensity score matching as an attempt to try and take that out, because we saw that as a confounder, so something that could be associated with both the exposure and the outcome.
So then from that, so if people, say, with Dupuytren disease go to hospital, and people who want bariatric surgery go to hospital, and then you control for that, do you get spurious problems, though? You can get a problem with some, collider bias if you control for that. So I'm surprised with that. What do you think? I don't know. I don't know enough about it, but this idea that if that's what you then control for, you can end up with an association appearing between two things that's maybe not true. Do you think that's relevant here, or is that dismissed?
I mean, it's something that we definitely thought about, and anyone who truly wants to get their nerd on can start Googling the obesity paradox, which is another hole of epidemiology you can get yourself into about, does obesity actually cause you to have an association with diseases that we can actually think that they are in modern medicine or not, and all these other things that get involved. For us, we didn't consider it a collider because we didn't think having Dupuytren surgery affected the amount of times you went to hospital 6 months prior to you having your obesity surgery. So that's why we considered it a confounder, so something that is associated but doesn't have an effect the other way around.
Okay.
The other thing I would just say on that is, of course, we propensity score matched on many different characteristics, not just on that one particular one. And so you would have to conceive of every one of those being a collider in exactly the same way for it to have a systematic bias to the analysis, I think. So I think each one kind of, if it did happen to be a collider, would sort of balance each other out in the propensity score matching.
I suppose I see what you mean, in that way. So all this extra nerdy stuff is in the supplementary area. And one of the things that is quite good as well is with a propensity score, rather than just saying we're matching on age, we're matching on gender, actually you get this number. So that's the whole point of it being a score. And that's where Duke was talking about, you want it to be as close to a randomized control trial where you flip a coin where the probability is 0.5. And for us, the probability was 0.59. Now, of course, if you've made the incorrect assumption, because all of this is based on assumptions, if you've made the wrong assumption, as you're talking about, Jamie, that something is a collider and not a confounder, then of course the whole thing is flawed. But from what we thought, we didn't think it was.
Sounds like really careful planning preparations. What's really key, as you've done here. Dave Warwick, you've also done a lot of research on Dupuytren's disease, built Southampton's Dupuytren scoring system, and you do a lot of Dupuytren's clinical work. What are your thoughts here?
Well, I thought it was a great paper, actually. So congratulations, Dom and Jenny, because I'd always heard about this thing about fat and Dupatrons, and I didn't kind of understand it or believe it too much. And then having read your paper, it is kind of pretty compelling. So I was very interested by that. And here's my other thought, is trying to bring this right into the real world, how confident you are with your data. We live in a medical legal world now, at least in the United Kingdom we do. The litigation rate is enormous. What would you tell a judge if a patient turned round and sued the bariatric surgeon because she went on and developed Dupuytren's disease, and hadn't been consented by the bariatric surgeon, if I do this operation, you might actually end up with a horrible finger problem. So firstly, can you tell from your study whether they just get the odd nodule or whether they end up with a horrible finger problem? And secondly, how confident are you with your data that you could say to the judge that on the balance of probability, your study shows that your weight loss surgery caused your Dupatrons? Because that's the legal test. So 2 questions. Firstly, does it cause bad Dupatrons that's likely to lead someone to sue? Do you have those data? And number 2, how confident are you that on the balance of probability it was the weight loss surgery that caused the Dupatrons rather than they were going to get it anyway?
So to take those in order, no, we don't have data on severity, although it does include patients who needed an operation for their Dupatrons. So you would assume that puts them in the relatively severe category. But it's important when you look at epidemiological studies to not necessarily infer causality. So this is an association. It is an increased risk, but it's not necessarily causal from that point of view. To really show causality, you need that unethical randomized controlled trial that I talked about earlier.
Yeah, I think the other thing to say is that this is a study of a population, so it's not of an individual. So you're looking at a whole population, and you're also looking at a relative risk. So what your risk was before and how much that's increased. And that's something that people like Matt Costa and the trialists are always on at me about. They're saying, so what does that objectively mean? Because if my risk of getting Dupatrons was low and then my risk has increased, but actually do I care about that because my risk has increased by a small amount? So when we talk about hazard ratios, we're talking about relative risk. That's the side element to that. But the main thing I would say is that we're talking about population and not an individual. And as we say, it's an association, it's not causality.
So the lawyers can't use your paper. That's good.
Well, I would also tell the judge to throw it out because the person is being very ungrateful because they've had all these other massive health benefits from having their bariatric surgery. So, you know.
I'm afraid gratitude doesn't stop people suing, unfortunately.
Yeah, and then they're going to say, but what about the obesity paradox? And then we're going to go down this spiral of epidemiological argument.
I pity the judge. The judge of all people is in for both barrels in this case, by the sounds of it, from the paper. Paul, you've got something.
Yeah, I just wanted to throw in some bias that we all have because we are surgeons. So when we see somebody with Dupuytrens, we are almost already, before having seen him or her, ready to operate. But we have to realize that although Dupuytren is very prevalent, we found that actually 20% of the people of over 50 years of age have signs of Dupuytren's, that having a contracture is actually quite rare. That's only about 4% in that population. So we are, as hand surgeons, I think we are very biased when we say Dupuytren, we immediately think about something that's really nasty.
Yeah, so interesting point to contextualize our own perspective. And what were your thoughts here handling this paper?
So again, another example of big data, large numbers, but a good example of a paper, I think, that explores a very good research question. Again, like some of you, I had some idea that fat may protect against Dupatrons or may cause Dupatrons with diabetes and the lot. But I mean, this paper was quite interesting in trying to answer that question. I think if you read this paper, for the audience out there, it is actually an example of a very, very good introduction. The introduction was very, very well written because it discussed the controversial issues around it, and then it gave a very clear research question what it's trying to answer. So a lot we can learn from this paper. The research methodology was very complicated. That's why I passed it on to Duke to look at that. But even then, I could somehow still understand it because of the way it was written, and I congratulate the authors for that. And questions I had, they they seem to have thought of this and that, even before I was, so I was thinking about this, but they seem to have thought of that. So that again is an example of a very good research methodology. What comments do I have? I think most of the edits were trying to make this paper more understandable for the average reader. So when I edit a paper, one thing I will always do is to put myself in the place of a reader. Can I understand this paper? What can I do to make this paper more understandable? So a lot of it, a lot of the edits were just simply asking the authors to explain a little bit more about the mechanism, why was the risk of Dupuytren's disease higher in women than in men, that kind of thing. But other than that, yeah, it was a joy to edit.
That's great. Well, no, thanks for the insights on that from the editorial office. I mean, we've already been going an hour. That's, our time is up. There's so much we could discuss here, and hopefully for those joining the audience, it's been a really great opportunity to think about some of these technical papers that are in the journal and actually what they mean for clinical practice, and hopefully we've delved into that a bit today as well. In terms of future dates, we don't have a future date yet because we've got a major event coming up. Do you want to say anything about that? Just for the audience?
Yes, it's what is it? 6 weeks now, is it?
Something like that.
Yeah, or just 2 months actually, 8 weeks. So, well, I think everybody in the audience should know what's coming up. Well, hope to see all of you in London. I think the early fee registration is over, but the late fee registration is coming up at the 1st of May. So please register if you haven't already done so. If you're presenting a paper or giving an invited talk, we really look forward to seeing you. That's great. Well, yes, that's it. So we'll regroup. We'll find more papers after IFSSH this summer. Hope to see you guys all in London. Really enjoyed this evening. Thank you so much to our fellows for presenting, Helen and Jantine. Thank you so much for our authors for joining. Justin, Dominic, Jenny, thank you so much. Thanks to our experts joining from Groningen and from Southampton, Paul Verker, Dave Warwick, Duke of Berkshire, thank you so much. And thank you, Editor-in-Chief. Really great to have you here sharing your insights from the other side of the table. And a big thanks to the team that put this together. So Christina's here. Matt, there's a whole team that put this together, and it really doesn't happen without them. So thank you so much. And thank you guys, everybody, for joining. Hopefully it's been useful. Hopefully you've learned something. Thanks very much.